So let's do a radical hypothetical, Darren. The radical hypothetical is a purchaser comes to your practice. I want you to imagine you're in a typical practice across the country. And the purchaser says, 50% of your reimbursement is going to be dependent on getting patients to goal on hemoglobin A1C. So the purchaser walks in, says that to the office manager. You're sitting, visiting a patient, and he comes out and says, the office manager comes out and says, we need to have a team meeting here. What happens to you as that pharmacist in the practice, if anything? What would you imagine would happen if that purchaser went to that office manager and said 50% of all revenue now is going to be tied to hemoglobin A1C?
So you had mentioned it was a hypothetical, and I'm thinking here that it's actually turning into a reality if we kind of think about where things are headed. And I think I would welcome something like that as you see value-based contracts being formed with certain medications and the costs associated with some of them, right? So you do these trials, in the clinical trials, results are X. In the real world, it doesn't translate into that, right? And so I don't know if A1C is the only marker to look at, and I think it would be a variety of them that you would need to look at because, again, A1C only tells, you know, a very small picture in the journey of a patient that has diabetes. But I think that, again, helps with that alignment, right? You have a manufacturer that's making this drug charging X, but, well, if it's not, you know, on the receiving end of it translating into those outcomes, well, should they have a responsibility, and should the patient have a responsibility, should the provider have a responsibility? Because anything that folks have a stake in or there's some skin in the game, that's where you're going to start seeing results and that shift happening.
Importantly, I want you to imagine that prior to that day, that purchaser walking into that office manager's office, that you were in a fee-for-service model, paid for doing, and then that day they walk in and say 50% of revenue tied to hemoglobin A1C, or some similar set of a cornucopia of measures. How does the practice change its view of you, if at all, and how does your day-to-day work change when that shift happens?
I think the way that shift happens, again, and I keep drawing back to our example because, again, I've been in that system for almost 10 years now, is there's less of I do this versus you do this because it's all coming out of one pocket, one bucket. And so it's basically get the patient to goal. It doesn't matter who does it because we're all on the same team. Where right now, what you were talking about, that silo, you go to that specialist, I'm only in charge of your eyes, I'm only in charge of your feet, I'm only in charge of your heart. But in our situation, in our system, that's my vet forever. They're always gonna cost us. So if I do something now, I'm benefiting from that. Whereas you don't see that in all systems because they might not be my member next year. So it'll be someone else's problem, right?
So diabetes is almost like an exemplar disease state where we've already discussed that very rare is the patient just to have diabetes. You've got metabolic syndrome. Oftentimes you have behavioral health challenges along the side, and you might have environmental home conditions along with that.
Social determinants.
And so you've got this exemplar condition with what you're saying is diabetes really becomes one of the key disease states to be prominent in payment and health system reform because it touches so many patients, it touches so many comorbidities and so many parallel disease states that it really forces a change to be a system to be paid differently and operate differently, right? And so, you know, back to the sort of policy and plan perspective, do you have some specific projects where you've seen some success and at least nibbling around the edges of this sort of team-based pay for performance, and how is it that the purchaser can kind of encourage this environment?
Yeah, so we're absolutely all in on this whole construct, and team-based care, collaborative care models. We set up our payment model to reward that, whether it be around a bundle payment for certain discrete situations like major joint replacement. Diabetes is so all-encompassing that for any attributed population, whether it be Richard's attributed population or some other clinician here in New Jersey, diabetes is going to be, so it's not a diabetes specific program, but it's rather around how we do the redesign, the process improvement, the PDSA cycles. They will frequently involve diabetes. We did one study with one of our high-performing groups in New Jersey where we actually had 100 patients that got usual care, and in this group that's a very, very high level of care, and then 100 patients that got peer coaching. So the persons who got the peer coaching actually had better outcomes and higher levels of satisfaction. So that's an example. We are looking at some of the diabetes prevention programs. We haven't selected one specifically, but that's certainly something we're very intrigued by. That kind of brings into the whole era of the digital self and digital health and how we get patients information to them. It seems like everybody's tethered, for good or for ill, tethered to their smartphone. So we see that is a way to get information to persons or communicate with persons, whether the person be 8 or 88. So that's another aspect that we're looking at, is how do we have this more kind of on-demand kind of care and information.